Welcome back. Today we will be covering facial development. So, as you know, bones can be made in two different ways. The endochondral way, which is where bones are formed through a hyaline cartilage model, and then those get ossified and then become bones. And there are the membrane or dermal bones where they are directly ossified bypassing a hyaline model, and that's how the bones of the face and the head are created. So first there's going to be the desmocranium, and then on the bottom it's going to be the chondrocranium, and those two meet when they develop, and then the occipital somites will migrate up, and then the nodal cord will form, making the central nervous system. The precordial cartilage eventually makes the trabecula cranii, so the spongy kind of structure between the bony plates of the skull, or the trabeculae, and it's the diplo, and this will eventually form the ethmoid bone. The hypophyseal cartilage is the precursor to the sphenoid bone. The paracordial cartilage is derived from the occipital and the first cervical sclerotome, and that will eventually make the base of the occipital bone. The otic capsule is the precursor to the periotic or the petromastoid bone, and eventually those will form the inner ear. And then the optic capsule will eventually form the orbital sphenoid and the alisphenoid, which will, eventually become the orbital cavity. And this is a nice diagram of what cartilage will make what. So the infant is born with these soft spots in the head, and they're made out of fibrous cartilage. The sutures are also made out of fibrous cartilage as well, and they are there so that the head can flex when being squeezed through the vaginal canal during delivery, and for the brain to expand. That's why when you see little kids from ages 1 to 3, their heads seem a lot larger than their body. It's because their brain is developing far more than the rest of their body, so it has to expand. Early fusion of the sutures can cause some problems, and we'll cover that later in the lecture. The posterior and anterolateral fontanelles will close by around 3 months, and then the anterior and the posterolateral fontanelles will close during the 2nd year, and then a few of the sutures won't fuse until age 18 or 24. So holoprosencephaly is very rare, and it's a disturbance in the early patterning of the forebrain. So here's a normal brain, here's a lobar brain, so look how these are connected. Semilobar, it hasn't even differentiated, and the alobar, there's no differentiation at all. Alobar is obviously the most severe, and there's going to be a defect in literally every structure. So it's in the forebrain, so the olfactory nerves and bulbs and tracts will be affected, along with the limbic, hippocampus, the mammillary bodies. Sometimes the corpus callosum is also affected, but usually the hindbrain isn't, as you can see. Sebocephaly, cyclopia, and proboscis are the general symptoms. Cyclopia clearly is the one eye. Proboscis is the protrusion of the lip without a philtrum. Sebocephaly is going to be the early fusion of the sutures, and of course there's a range. So, as we were talking before, the premature closure of sutures can have a lot of problem because they're usually indicators of a lot of syndromes, and a lot of them are the mutations of FGFR 1, 2, and 3 receptors, and those kind of are associated with brain development and ossification. And then twist and MSX2 transcription factors are also involved, along with the ligand epinephrine B1. And generally, the sagittal and the coronal sutures are the most commonly affected. As you can see here, coronal suture is fused. So to compensate, there's going to be like a frontal bossing and then occipital enlargement. Here is the I can't even pronounce it, but is when the head is triangular shaped. Here, as you can see, the parietal sutures have fused early, and like I said, it's associated with a lot of other genetic defects. Okay, so Apert syndrome is caused by FGFR2, and it's associated with acrocephalosyndactyly. So that means that the coronal suture has fused early, and then there's going to be fusion of the digits. And then the craniofrontal nasal dysplasia is caused by an EFNB1 mutation. This is also going to be caused by a fusion of the coronal suture. There's going to be usually like a cleft down the center of the face. Sometimes it's not very visible, but in this particular patient it is on the forehead, but it's more visible on the tip of the nose. The mouth is going to be unusually wide. The eyes are going to be spaced very far apart, and the fingers and toes are generally going to be malformed. This is X-linked, but curiously enough, the females are going to be more affected, and the Gregg-cephalopolysyndactyly is going to be a mutation in GLI3, and it's inherited in autosomal dominant pattern. And there are going to be like 3 criteria: the fusion of the toes, fusion of the fingers, and then there's going to be a early fusion of the sagittal suture. Wait, I'm sorry, it's not the sagittal suture. It's going to be also a fusion of the coronal suture. So there's going to be some frontal bossing. Okay, so there is going to be some conditions where there's going to be a complete or partial absence of the neurocranium. Remember, that's like the top of the skull. And that's also associated with extensive defects of the vertebral column. That could be spina bifida in any of the forms. Remember, spina bifida can be mild to very severe. And then there's going to be meroencephaly or anencephaly associated with that. Meroencephaly is going to be like the partial absence of the forebrain, while anencephaly is going to be complete absence. This is anencephaly right here. And it is a result from the failure of the cranial end of the neural tube to close. Microcephaly, it means that the brain is too small. It can be mild or it can be severe, and that is caused by early fontanelle closure and suture fusion. And I didn't really write this down, and I think it should be fairly obvious, but all of these skull deformations will result in developmental delay and intellectual disability. Okay, so let's go on to the pharyngeal apparatus. There's going to be 6 pairs, but the 5th arch will disappear. The first arch will form on day 22, the second and the third will form on day 424, and then the 4th and 6th arch will form on day 29. A pharyngeal arch is made out of the central cartilaginous skeletal element, which come from the neurocrest cell, and then the striated muscle rudiments, like right here. We'll eventually, consider them somites, and those will be made from the head mesoderm, and those are going to be innervated by an arch-specific cranial nerve. And all of that is associated with some aortic artery. As you can see here, the second and the third are like shown here, and then the fourth and sixth are going to be within, so they're not visible from the surface. And here's the nasal placode. Eventually they'll make the nose, but here, more importantly, is the stomatium, and that is our future mouth. And right around here is the first arch. So first, second, third, or yes, both of them, second, third. And then right here is going to be our primordial heart. Okay, so the external pharyngeal clefts or grooves are separated from the pharyngeal pouches by a membrane, and those membranes are important for the segmentation later on. The membranes are made of ectoderm and endoderm. Here we go, here's the stomatium, and then on the outside is going to be our arches, and the pouches are forming. And then oropharyngeal membrane is right here. Eventually it will migrate out, and then through apoptosis the mouth will be formed. Here's this 32nd day of development, pardon me. The placodes are on here on the side. Here's the frontal nasal prominence. The optic placode is going to be eventually like our eyes. And here's our heart, liver, and here's our little arm. So this is a pretty good representation of the pharyngeal arches. Just remember, like, you know, it kind of goes from top to bottom, really. So it goes from, like, you know, head all the way to, you know, throat. Okay, so the first arch is going to be made out of, like, the maxillary prominence, and that will make the palatopterygoquadrate, and eventually it will create the mandibular prominence. It's also made of, like, the Meckel's cartilage. And then the second arch, the Reichardt's cartilage, will form from the neurocrest cells of the ribomere 4 of the hindbrain. So here's the hindbrain region, and see right here, hindbrain number 4. It's going to be signaled or influenced by HOX-A2, and midbrain is going to be OTX2. And then these, remember, these grooves are going to separate everything, and then the foramen cecum is right here. And the third arch, the neurocrest cells, are going to come from the myelencephalon. And then the fourth and sixth will come from the neurocrest cells, and there's going to be some mesodermal boundary forming at the tracheal cartilage. So around the tracheal groove, the tracheal cartilage will eventually, like, you know, form. So, sorry. All the veins in the body really arise from the aortic sac, and then the arteries will connect the paired ventral aorta with the paired dorsal aorta, as you can see here. And then the system will remodel to produce the great arteries of the thorax and the branches, and eventually those will, like, you know, deviate and then supply the head and the neck. So arch 1 is made out of the paraxial mesoderm, and it will be making eventually the muscles of mastication, so the masseter and the temporalis. And then it's going to be innervated by cranial nerve number 5. The second arch is also made out of the paraxial mesoderm. Instead, it will make the muscles for facial expression, so like the buccinator, the frontalis, surprisingly enough, the orbicularis oculi. And then that's going to be innervated by cranial nerve number 7. And then arch 3 will make the stylopharyngeus muscles, and those will be like the stylopharyngeal muscle, and it's going to also make the hyoid bone, and then it's going to be innervated by the glossopharyngeal nerve. And then arches 4 and 6, those are going to make the superior, middle, and inferior constrictors of, like, the throat. So it's like the omohyoid and then the infrahyoid and all of those. Those are going to be innervated by the vagus nerve, so cranial nerve number 10, and it's also going to make a bunch of like cartilages in the throat, like the cricoid and the thyroid and the arytenoid cartilages. So there's going to be 5 prominences. It's of the face, and then eventually, they all merge together and then make the face. By week number 5, the maxillary prominences will grow ventrally and medially, and then the nasal placoids would form, and then by the end of the week, 6 auricular hillock will form around the first pharyngeal groove, and those will eventually make the ear. And then by the 6th week, the nasal placoid will form the pits, and then divide the frontal nasal prominence into the lateral and the medial nasal processes. And then the medial nasal processes will fuse to make the primordium of the bridge and septum. So as we can see, problems within week 5 to 6.5. There's going to be some problems with fusion, and these will make the facial abnormalities. So the 5 prominences are going to be the nasal placoids, and then the maxillary prominences, and then the primordial palate. So by week 7, the nasolacrimal groove will form the duct and the lacrimal sac. So those will form the tear ducts. And then by the end of the week, the the medial nasal processes will form to form the intermaxillary process. And then the maxillary prominences will meet, and they fuse with the intermaxillary process. And then the intermaxillary process will give rise to the philtrum in the front of the face and the primary palate. So you can see here's the medial nasal prominence, and then this is the lateral. So these are the nostrils. And then here is the ear down here. The intermandibular depressions were going to be filled in during the weeks 4 to 5 by the proliferation of the mesenchyme. And then the mouth will get smaller as the cheeks enlarge. And the cheeks are not going to be really made of muscle at all. These are going to be very underdeveloped muscle until the child starts chewing and eating solid foods. It's mostly going to be made out of adipose fat, which is why, when babies come out, their cheeks are pudgy. And then the brain, of course, enlarges, and the cranial cavity gets bigger, and then the eyes will orient. So first they're kind of on the sides, and then they kind of migrate in medially. And then the ears will rise. So as you can see, we can tell where in development something has happened by looking at the outside features. The secondary palate is formed from the primordium of the hard and soft parts of the palate. It forms in the 6th week from the lateral palatine processes, so it forms after the primary palate. And then week 7 to 8, the lateral palatine processes assume the horizontal position above the tongue, so they orient right here. And then the bone will develop, they fuse, and then they close. But in the posterior area, they don't ossify, and instead they still fuse, but they form the soft palate instead, along with the uvula. Facial clefting is going to be the problems with the process of fusion. The anterior cleft anomalies are going to be more in the male child, so it's going to be the primary palate not fusing, while the posterior cleft anomalies are more in females. As you can see here, there's the posterior, so that's going to be the secondary palate. Which ones are more serious? It depends. An anterior cleft palate is problematic because the child can't feed correctly. How is the child to be able to latch onto the nipple when there's going to be an open here? A problem is that the milk might come out and then go into the nose, and the child might aspirate. However, it is fairly easy to correct with surgery. Posteriorly, there is going to be a greater risk for infection. So back here with that opening, it can travel straight to the brain and kill a child. Also, it is harder to correct with surgery. So this can be caused by medication like anti-epileptic medications such as Dilantin or retinols. So Accutane is going to cause this, and corticosteroid usage. It's also some kind of genetic inheritance. So usually it's one single mutant genes, and it's associated with a lot of trisomy syndromes. And the median cleft lip is going to be really rare. Usually it's just going to be like unilateral. It's like a median will be like straight down the middle, but usually that doesn't form. It's a characteristic feature of the Mohs syndrome. Bilateral cleft lip is also pretty rare and very, very hard to fix, as you can see here. So first arch syndrome is also known as Treacher-Collins syndrome. As you can see here, it's going to be like the droopy eyes and the malformed ears. These patients also have some form of like, deafness involved. It's an autosomal dominant disorder where TCOF1 gene is going to be mutated. Pierre-Robin sequence is going to be like the malformation or almost non-formation of a jaw. So the jaw is going to be very, very small. The chin is going to be like very weak. The tongue is large compared to the jaw, of course, and this is a problem because it can result in some airway obstruction. Okay, so that's it for now. Thank you for your attention and good luck studying.